Pediatric hearts are different. Fetal circulation is the biggest cardiac difference in adults and children. However, in most cases, fetal circulation converts over to regular circulation within just a few days of birth. We've already talked a lot about fetal circulation in the OB course, so we're going to focus on the other things that are different. The right ventricle is larger than the left at birth. Why? Because the high pulmonary resistance during fetal life forced the right ventricle to muscle up and be as strong as the left. As pulmonary resistance drops, the right ventricle muscle size reduces to match that of the left ventricle by 1 month of age. After birth, the higher systemic pressure, vascular pressure, forces the left ventricle to increase in size quickly. It starts pumping iron. Kind of think about it like that. That decreased left ventricle is one of the reasons why babies have such low systolic blood pressure. Blood pressure should rise and reach adult levels by puberty. By 2 months of age, the level of resistance in pulmonary vessels is the same as an adult. However, in conditions of hypoxia, acidosis, hypothermia, and prolonged pulmonary vasoconstriction, these things can lead to the development of PPHN, or that's that persistent pulmonary hypertension. It's like persistent fetal circulation, basically. This is a very bad deal for kiddos. If there is pulmonary hypertension, it's very difficult for gas exchange to occur. Babies die from this. This is a big deal. I also want you to recall that chronic hypoxia stimulates bone marrow to make more red blood cells to carry around more oxygen, right? It's a pretty smart mechanism. If the body notices that, hey, we are tired of being hypoxic, we don't have enough delivery trucks, trucking oxygen around, we'll just make more trucks. It calls back to the GM plant, says, hey, kick out some more trucks. That's, the GM plant, of course, would be your bone marrow. So this is kind of what happens in children with cardiac defects. It's not uncommon for children with a cyanotic heart defect to become polycythemic because, again, the body says, hey, we're hypoxic, we need more trucks. But there's also a risk that with that you get platelet dysfunction and thromboembolism too. Baby hearts have little reserve during infancy. Their muscle fibers cannot expand and stretch to increase for stroke volume. So instead, they speed up the rate. This is why children have such higher resting heart rates. They have faster resting heart rates than like adults do. Then when you add the physiologic stress to the heart, as in fever, illness, exercise, or respiratory distress, then their heart rate increases again. Infants have a much higher risk of heart failure than older children because the immature heart is more sensitive to volume or pressure overload. By age 5, the heart muscle is fully developed, so they can start to lower their heart rate because they can increase stroke volume to maintain their cardiac output. But that doesn't happen until age 5. This is just a nice graphic of pediatric blood flow. It helps to understand pressure gradients, flow, and resistance within circulation. In general, as blood is pumped, it flows from an area of high pressure to one of low pressure, and it's going to take the path of least resistance. In general, the higher the pressure gradient, the faster the rate of flow. The higher the resistance, the slower the rate of flow. See how I talked faster and I talked slower? Hopefully that will help you guys remember this. Normally, pressure on the right side of the heart is lower than that on the left side, and the resistance in the pulmonary circulation is less than that of the systemic circulation. That's what should happen when a baby takes their first breath. Remember all those crazy steps about initiation of breathing for babies? It was a ton, wasn't it? When a baby takes their first breath, the systemic pressure rises, which allows blood to flow over to the lungs because the blood is going to follow the path of least resistance. Anyway, so pressure is higher on the left side of the heart than the right side. If you have an abnormal connection between the heart chambers, like a septal defect, the blood is going to flow from the left to the right. Anomalies that result in cyanosis, like obstructions or things that increase pulmonary vascular resistance, will have blood shunting from right to left. Cyanosis that Cyanosis may also result from a defect that allows mixing of oxygenated and deoxygenated blood within the heart chambers or great arteries. The fetal heart begins developing on day 18 of pregnancy. That's only 4 days after a missed period. The septum between the atria and the ventricles and blood vessels begins to form during weeks 4 and 5 of the pregnancy. Defects can be an isolated event. They can be a result of a genetic mutation, or it can be due to an environmental effect or a combination. Some of the genetic disorders associated with cardiac defects include trisomy 13, 18, 21, something called Creutzfeldt syndrome, Turner syndrome, Noonan syndrome, and DeGeorge syndrome. But basically, I don't care if you memorize this list. I just kind of want you guys to hear all these different syndromes and know that those are associated with some kind of a heart defect, because you'll never be able to remember all this. All right, so what are the clinical manifestations of a congenital heart defect? Well, a murmur. A loud murmur means that there's blood that's being forced with a higher than normal pressure to get through somewhere that is either narrowed or it's through a shunt. Newborns may be asymptomatic initially, but then they develop symptoms within the first few days. Kind of a nice reason why it's nice when people choose to have their baby in a hospital and stay for 24, 48 hours, 36 hours so we can watch things, make sure everything looks good. Just saying. Some babies can be symptomatic from the very beginning. There is a great link underneath murmur where if you want to practice and listen to heart sounds, you can listen to some there. In older children, of course, these are things you're looking for. Exercise intolerance. When kids go outside to play and they play for a minute and they come back in and they're red-faced and they're out of breath and they're exhausted, that's the sign that there's a cardiac defect. Something's going on. Kids who complain about chest pain, their arteries and their vessels they should be wide open. So they should not be complaining about chest pain. Arrhythmias, syncope, and of course, sudden death. Your textbook describes all these procedures if you are unfamiliar with any of these. So what is your nursing care that is associated with pediatric cardiac catheterizations? Well, you have pre-op and you have post-op care. Usually the intra-op, during the actual catheterization, you're going to have special nurses who are in the cath lab who'll be monitoring a lot of that stuff. But pre-op, baseline vitals. It seems silly to mention that, but baseline vitals are really important for a comparison with your post-op. I listed out some other labs and other, nursing responsibilities, information you want to collect. During the procedure itself, nurses take on more of a monitoring role and maybe a distraction role until the child is sedated and asleep. Immediately afterwards, pressure is going to be held on that op site. Well, it's not really an op site, but on the incision site for 15 minutes. The child will be on bed rest for 4 to 6 hours or 6 to 8 hours if it was an arterial catheterization. This means no flexion of the hips, so the child will be laying down flat. This means that they need a lot of distraction and entertainment, because do children like to lay flat? Not for very long, and really not ever. So lots and lots of distraction, lots and lots of entertainment, and do not leave them alone or they will sit up and they will move. Post-op, it's going to be important to watch the monitor. You're looking for arrhythmias. Watch your the incision site for any kind of bleeding, for hematoma, watching for infection, but signs and symptoms of infection immediately post-op could be free. You're probably not going to find them. Vitals, again, make sure you assess lower extremity perfusion. If they went into the child's right groin, make sure you check pulses in the right foot. Make sure you compare those pulses with those that are found in the left foot as well. Always compare right to left, remember? INO, contrast medium may cause some diuresis, and if the patient is a cardiac patient, they may be on diuretics anyway, so you'll have to monitor INO. And then be very supportive of the parents and the child's emotions. It's a lot for people to take in. So now let's talk about some actual cardiac defects. We're going to start with the defects that increase your pulmonary blood flow. Those are listed for you on your slide. These defects occur when the blood shunts from the left over to the right, and then that is going to increase the amount of blood that's going to the lungs, which makes sense, right? The child will develop signs and symptoms of CHF, congestive heart failure, eventually, but it depends on how much blood is being sent over to the lungs on how quickly these symptoms develop. Pages 1322 and 1323 give you specific information about these conditions. Clinical manifestations. Children may be asymptomatic or they may have all of these things that are listed for you on your slide. Things I want you to be aware of. If children have some sort of cardiac defect, odds are they're going to have a murmur. Now, whether or not you can hear that murmur, it kind of is up to your nursing skills. It's up to, how in tune you are to heart sounds. I will tell you guys a secret. I couldn't hear murmurs at all for like the first few years that I was a nurse. And granted, I worked on babies and their hearts beat so fast all the time anyway that I was just lucky to count it, honestly. And then I would read I'd read back, my predecessors, nursing notes, and she'd say that she heard a murmur, and I would go back and listen. I'm like, where did you hear that murmur? But then one day we had a baby who had a very obvious cardiac defect, and his murmur was so loud it sounded like a dishwasher. I mean, there was no denying that there was extra whooshes when I was listening. And that was like my tipping point of like, oh, now I hear the murmur. So then I kind of developed an ear for it. And then pretty soon I was that nurse who could pick up and hear murmurs that other people couldn't hear. So just know that if you can't hear it right away, it's okay. If you're going to, you will over time pick that skill up. Tachycardia, tachypnea, that seems to kind of go without saying. Increased metabolic rate, yeah, because their heart's working really hard. Poor feeder. This is a classic symptom of a baby who has cardiac defects. Sucking a bottle or breastfeeding just takes so much energy, and these babies just don't have it. They just don't. Sweating with feeds, again, that just shows increased work of effort and breathing just trying to eat. Cardiac kids generally do not gain weight well because they are working so hard. It takes so much energy for them just to eat and digest their food. They don't have a lot left over to pack on some weight and grow. When the CHF kicks in, then you're going to have the classic signs of CHF like dyspnea, tachypnea, intercostal retractions, periorbital edema, and lung infections. CHF babies are susceptible to lung infections because they have wet lungs all the time, which supports bacteria. And not just wet, with dirty rainwater wet lungs, but wet with nutritious blood. Bacteria love blood. I mean, it's like taking them to an all-you-can-eat buffet. Bacteria love blood. All right, so diagnosis and treatment. I referenced some pages in your textbook. In general, surgery is going to be required to fix whatever it is that's causing the increased delivery of blood to the lungs. Treatment may include waiting until the child is symptomatic to fix the defect, because that will give the child some time to grow bigger. In the case of a PDA, medicines such as ibuprofen or indomethacin can be given to help close that passageway. There are some risks associated with that. Kidney failure is one of them. It's kind of a big risk. So before the neoprofen is the one that we use in babies, or the indomethacin is given, the doctors will draw labs and they will monitor kidney function before the infusion of the indomethacin, and then after and before the next dose, and so on and so forth. Some defects like a PDA or small ASDs, some of those are going to close all by themselves. So, that's, your best case scenario. Surgery, they can do surgery to close ASDs and VSDs and PDAs and all these kinds of things. So that's always an option. All All right, PDA, not public display of affection either. Patent ductus arteriosus in the nurse world, medical world. Recall that prenatally, blood flows through the right atrium and flows over to the left ventricle via the PFO, thereby bypassing the lungs. Some still flows into the right ventricle and up the pulmonary artery, where systemic vascular resistance is high, so it hitches a ride through the PFO into the aorta, where it's pumped out into the body. In the case of a PDA, after birth, pulmonary blood flow is established, so blood in the aorta now has a higher pressure than that in the pulmonary artery. So blood takes a ride on the PDA highway again, but this time it goes back to the lungs for a second time. This increases the overall blood flow to the lungs. An ASD is exactly that. There is an opening in this atrial septum that allows blood from the left side to come over and mix with the blood from the right. The defect may be small, like a PFO, or large, like the entire septum could be missing. 33 to 50% of children with an ASD have another heart defect as well, but an ASD can occur as an isolated defect. A ventricular septal defect, or VSD, is very much like an ASD, except that this time the defect is between the ventricles instead of the atrium. Blood again is forced from the left side over to the right side. This type of defect occurs in 15 to 20% of cases and can occur in conjunction with other defects, or it can be an isolated defect as well. All right. So AV canal, these poor hearts, they are just a mess. This means that there's an ASD and a VSD and tricuspid and mitral valve defects. About 4% of children with cardiac defects have an AV canal defect. 70% of that 4% have Down syndrome. So this is a pretty common defect for children who have Down syndrome. The repair is going to be surgical. Prognosis it's pretty good. They'll have some mitral valve insufficiency and maybe some arrhythmias post-op, but they look pretty good.